So our patient is a 74-year-old female who presents with exertional dyspnea. 18 years ago, she had a Medtronic Freestyle number 25 aortic valve placed for severe aortic valve regurgitation. Her comorbidities include frailty, mild dementia, chronic lung disease, hypertension, and a prior stroke. Her STS score is 3.7%. Her transthoracic echo demonstrates a preserved ejection fraction, severe aortic valve regurgitation, and moderate aortic valve stenosis with a mean gradient of 25 millimeters of mercury. And her CT demonstrates patent iliofemoral vessels, as well as mild dilatation of the ascending aorta and calcification in the root of the valve replacement. As you can see, her left coronary height is 11 millimeters of mercury. Her valve to coronary distance is only 2.6 millimeters, and you can see on the CT where her leaflet extends above the takeoff of the left main. On the right, she also has a height of 9.5 millimeters, and the valve to coronary distance is 3 millimeters.
So I'll summarize the case and the plan. It's a 74-year-old lady with severely regurgitant freestyle label 25, deemed with elevated risk for redo surgery. Our procedural strategy is to use a sentinel device to do a double basilica for the left and the right casts, and to deploy an Evolut Pro 26 millimeter valve. Next slide, please. So we'll go through the basilica technique in detail during the procedure itself. We didn't want to run a presentation now, but basically it's a technique by prosthetic aortic scallop intentional laceration to prevent iatrogenic coronary artery obstruction, in which we lacerate transcatheterally a leaflet in order to enable flow towards the sinus and to prevent coronary obstruction. And we think this is a good opportunity to thank and congratulate our great friends from the NIH and others, Jafar Khan and Robert Lederman, Shuli Adam and Vasilis, Toby Rogers, and the Iki Komatsu that really pioneered the transcatheter wire electrification techniques from the Transcava, Lampoon, and Basilica, which we see increasing in demand and in clinical practice.
That's perfect. So I'm going to pass it to Dr. Mackinson now. He'll show us some of the initial images and what the challenges of placing a transcatheter aortic valve and why we chose to do the Basilica procedure.
Well, thank you. I'm starting with the short axis in 2D for this aortic valve, a freestyle Medtronic, as we heard. If you note, the left coronary is nicely seen in this short axis, and you see a lot of movement of the leaflets. They appear to be thickened. Now I'm going to show you a 3D, which I'm going to turn around. This is the view from the left ventricular outflow tract. Turning it around, looking from the aortic side, you appreciate all the calcification on either side, as well as these thickened leaflets, some of which are prolapsing, which I'm going to show you in a moment. Here's the significance of the aortic regurgitation. The LVOT in this particular image is on the right-hand side, and the aortic side is here. So you see tremendous backflow into the left ventricle. Again, we'll see it again from a different point of view, which was opportunity to go deep transgastric. And you have a color compare image in 2D with significant AI and the forward flow PISA, and on the left-hand side, the thickened leaflets again. We also took a moment to assess the pressure half-time as a quantitative measure for AI, and we measure 240, which is close to severe, just on the border between moderate and severe. In some guidelines, that would be considered severe for sure. Here's a short axis of her left ventricle, certainly preserved LV function. Now, when we use the 3D to assess not only the size, which was predetermined by a CT, we confirmed a very similar sizing as you see it here. But we also had an opportunity then to identify the offtake of the left coronary in 3D in this long axis view. You may appreciate the offtake here, and then you see the leaflet, the left coronary cusp coming out of that coronary ostium and going back and forth, again, suggesting the high risk for potential obstruction during the TAVR procedure if we were not to do basilica. This also lends itself to measure and confirm the height, which I measured out at 11 millimeters for this particular situation. And I think, unless there are any questions, we're going to stop here with the pre-assessment images.
Okay, so just one last comment to make. We were thrown a small curveball at the beginning of the procedure. It wasn't really clearly identified on the pre-angiograms, but we identified a severe lesion at the ostium of the right coronary artery. So, Jamie, maybe you walk us through how you managed that and made sure that that stent didn't get in the way of what we were doing.
Sure thing. Thanks, Mark. Pretty straightforward ostial right coronary lesion. Obviously, the big concern that Danny and I discussed was hanging a stent out into the aorta in a scenario where you're obviously going to do a lot of catheter manipulation and not wanting to have a, kind of a dangling stent in the aorta engage with or interact with our catheter. So after following cutting balloon and stenting, we used an osteoflash system, which is a nice balloon-in-balloon system. Want to go back to that picture, Danny? Yeah. So this one, it's got an anchoring balloon, which you put at the ostium, and then it's got a bulbous balloon on the aortic side to just help kind of compress the whatever part of the stent might be hanging out back to the aortic wall. So I think we got a really nice result with that, and we kind of quickly moved on from there.
So yeah, initially developed fractional renal stenting, and really is an attractive device in the coronary, especially when you want to really get that flush apposition of the stent. So at this point, what I'll do is I'll ask Danny maybe catch us up as to where we are, and then, yeah, sure, go. I'm sorry, Francesco.
No, we are silent, but since you stopped talking for a second, I just want to ask you one question, one single question. I see you using a Sentinel. In this particular case, is it for you standard practice, or you do this just because of this very complex Basilica procedure?
Well,
yeah, so Jamie, you're talking about Sentinel, right?
Yeah.
So I'll ask Jamie to comment. He's been very proactive in using these devices. So Jamie, your comments about use of Sentinel?
Yeah, I mean, we have adopted it lab-wide on our transcatheter aortic and mitral cases. So much MitraClip, but any valve replacement case. And, the safety profile of the device as demonstrated in multiple trials is very favorable. So the only real downside at this moment is cost, which hopefully will be addressed, but we've kind of decided that we think our patients, if you believe the data about, the meta-analysis would suggest there's an almost 50% reduction in hazard, and that seems good enough for us. So we have been using it pretty routinely. Danny put it in, and what would you say, Danny? It went in had 35 seconds or something like that. I mean, very quickly.
I mean, we use it routinely. Maybe if it was one of the first cases, it would be more challenging.
Yeah.
So we've adopted, as mentioned, universally. Just in the interest of time, maybe Danny just catch us up, and then we'll take some questions.
Okay. So basically, we talked about PCI and Sentinel, but this is our target and for treatment. We have the Freestyle 25, severely regurgitant, as you can see. You can see even the leaflet of the left cusp, how it comes up, and if it will be deflected, it will occlude the left main. Here is, go forward a bit. More selective injection into the left cusp, and you can appreciate the danger of that stentless valve. Stentless valves are the most problematic surgical valves for the risk for coronary obstruction, higher risk than externally mounted surgical valve leaflets. And basically, we have many things that we can discuss regarding the Basilica. Maybe one thing that we should describe, there are two views that we need to appreciate before we try to cross the leaflet. One view is the side view, in which we we see the leaflet as a line, and we try to see the penetration angle towards it. And another one is the front view, in which we target the leaflet like that, and we want to see that we are in more or less the middle part of the leaflet, not too much to the right, not too much to the left. This is the side view of the left cusp. And basically, this is, actually we used here, this is an AL3 injection, and I switched to AL4 8 French. I found an AL4 8 French, was very challenging to have it, that it's the right guide for this case because the aorta is dilated. Here we have a snare waiting inside the LVOT with a platinum wire to just anchor us. The snare is a gooseneck 20 millimeter. And we have an IM catheter bulging out of the AL4 guide. So this is the front view. We are more or less in the middle part of the cusp. That's the side view, in which we did it just before being live. We crossed the left cusp leaflet. We snared that.
Sorry, Danny, the crossing is done with or without RF energy?
With.
With the, you mean electro?
Yeah.
Yes, with the 50 watt electrification of the stator wire. So we have a telescope of 4 things delivering the stator wire and 3 other things. We have the AL4, we have the IM inside it. Inside the IM, we have a micro catheter that is called piggyback, and we'll show you it in a second. And inside the piggyback, we have the stator wire. And now we pierced the leaflet after electrifying the wire, and we are snaring it. And after doing that, we brought back a kinked and denuded wire towards the left cusp. It's just where it enters. The kink is where the leaflet is. Usually we do more strong, smaller curve kinks than this one, but that's a kink that we have for the left cusp. And you can see the AL8 French guide and the multi-purpose guide from both sides. So there is a loop for the left cusp ready to tear and create the laceration of the left cusp.
And just to be clear, Danny, that is the estato that we snared before we externalized it.
Correct.
You make the kink on the back table. So you don't make that up front, obviously, because it's hard to deliver. After you've kind of intercepted that wire with the snare, then we kink it, and then Danny drove that forward. So
we may be able to show you everything because we have a second leaflet to work on. So for that second leaflet, we'll use, that's more or less the side view of the right cusp. You can see an 8 French multi-purpose. That's the darker gray catheter that you see in the screen, positioned, and we have another snare now waiting in the LVOT. Positioning picture, that's more or less the front view. We want to see that you are in the center of the cusp. And basically, this is where we are right now. So maybe we'll just go ahead.
I'll ask Danny to continue working, and then maybe we'll take some questions from the panel. Francesco?
Yeah, so I would like to have Vasily. We have Vasily on the podium, so probably he can tell us whether there is any difference to your standard practice. You've done more than 40 of these cases. Do you agree with these tools on the table, or you have something new?
Thank you for asking me to comment. I think it's very important for the audience to realize that this is almost certainly, or we should say very high risk for coronary obstruction, and that your options in the past have been chimney stenting, hospice care, open surgery, one of those 3. I think this technique allows you to extend a bit more patients that can be done with TAVR. So we're a big proponent of this. We're doing plenty. The 30-patient ID was presented yesterday by Jafar Khan. You can see those results online, and they look excellent. The use of the catheters that Danny's showing are the standard catheters, usually an AL3 or an AL4 in this case, since it's a bigger root. to get over to the left, some either pre-shaped JR4 catheter or multi-purpose. What's important is that you are burning at the base of the leaflet and not burning out of the LVOT, either into the free walls or into the left atrium. So I think this combination is quite good, and this patient is at high risk. There's a lot of aortic insufficiency at baseline, which means the patient should tolerate pretty well. And I think if you're ready to burn, maybe I can
Yes.
Yeah.
hold tight.
So we're about to burn now, so we'll just give us a second. We're going to pull back the
Can
TE
you pull
probe.
back the probe for just a second for us?
And we're going to,
So,
basically we have, I'll
Bobby
call it
on.
please.
Just a sec. Bobby on? Okay.
So that's going through the leaflet of the right cusp. And now we'll try to snare it. Just to review what you see in the,
Yep. you got it.
perfect. What you see in the left ventricle, you see a platinum plus, and that's there just to support that there's no problem with repositioning the snare back and forth. That you won't, if you wind up getting back into the aorta, you have no problem getting back into the ventricle. So he was able to traverse it. He captured it, and now the plan is to basically using that
Platinum out.
snare to basically bring the tip of the estado retrograde back into the receiving catheter,
Okay.
the snare catheter, and then ultimately we'll set our kink on the wire and then be able to snare it.
Yeah, let's move slow.
So, Mark, at this moment,
Yes.
we have one wire in the left coronary. You're working on the right. You didn't cut the left yet, right? So you want to do it
Correct.
simultaneously.
Right, so the plan that we thought would be the safest would be to initially cut the right, and then after we cut the right, we were going to put a confida in the left ventricle
Okay.
and
Lock-
be
locked and
set
clamped.
up to deploy the valve and then cut the left.
All right.
And the rationale for that was just from a safety standpoint. Now, she has very significant AI, so she should tolerate it, but obviously we're being careful. Danny's going to show how just the technique of denuding the wire. If you could put the...
So basically, the piggyback has a mechanism that it can lock over the wire. And we would like to create an area in which all the electrification will concentrate on the leaflet. So the proper technique is to denude the wire, not circumferentially, but approximately 5 millimeter after the piggyback exit. And then to create a kink in the middle part of it.
Don't cut your fingers, Danny.
No.
So it's worth noting that we're using a 300 centimeter wire. It's 150 millimeter piggyback. So if you bring the piggyback towards the end of the wire, then you essentially know that you're making your kink more or less in the middle of the wire, which is helpful because we're going to now externalize that wire, and we want to have roughly equal lengths on either side.
Okay.
Yeah, and again, I think it's another opportune moment just to say, congratulate the team at the NIH who really provided us tremendous insight on how to do this procedure. We've obviously made some nuanced adjustments under their guidance, but overall, they just did a tremendous amount of preclinical work to really increase the safety almost from the initiation. Even procedures like Lampoon and Transcaval, which we do quite a few, we really just want to reach out to the great work that team has done. So right now he's driving up as Jamie is pulling, and the idea right now is to get that kink to be right at the base of that cusp. And you'll see it come in, it almost snaps into place. They try to keep their catheters somewhat...
You can see a dot there. The dot on the wire is related to the left cusp. Maybe I'll move to a slightly different projection that you'll appreciate it. Okay, not better.
Got that other funny wire in there, so...
The two catheters are kissing. I'll just pull a bit the 8 French.
Okay.
You can see shortly the new kink coming into place.
Just
So you
about
see it coming
there.
from left to right, and it's just there probably now, huh? You guys feel it?
Yep.
Perfect.
There it is.
So our aim, maybe we'll show what we have with regard to catheters. We have a 16 French dry seal in the right femoral artery. We have 2 arterial sheaths in the left femoral artery that were utilized for the left cusp loop. One is 8 French and one is 6 French. Through the 16 French dry seal, we created now the loop in the right cusp using the 2 multi-purpose catheters that you just saw. We will do the laceration of the right cusp first in order to have the big sheath ready for us for leaflet for TAVR implantation. So that will be the first cusp that we'll tear.
Okay.
Okay.
All right, let's bring the Bovie
Let's
over.
connect the dextrose.
Hey guys, this is Maurice Serrano. You're putting this through a calcified valve. Any concern about what happens to a calcified valve when you try to cut it?
He's breaking a calcified valve. Any issues that you...
Well, yesterday we had a severely stenotic valve, and 2 days ago, severely calcified valves. Both of these
Right,
traversals
so-
were...
And certainly the Lampoon experience was
Those
similar.
look
That you know the
So
often
in terms of
anti-mitral
calcification, we've done a number of valves. We've actually done bicuspids as well along the raphe or near it. Other than the opportunity, the real key is that you have a good fulcrum, that when you're pulling back, you get a more or less straight tear. And we've been successful with that to date. I don't think we've had any issues where we're unable to tear at this point, at least on the aortic side. We've had some issues in very calcified anterior leaflets of the mitral valve.
Yeah.
Danny, this is Samir here.
It's a
Hi
lot
to
more
everyone.
graceful when the electricity works, but at the end of the day, they all tear.
Mark,
Basically, we want the 2 catheters of the
Mark, this is Samir here. As
right
you know
cusp
that
loop to be closed.
one of the
Yeah, we're having a
surgeons-
little trouble hearing whoever's speaking now. If you could talk more closely to the mic, that would be helpful. Thank you.
Hey, Mark, this is Samir here. As you know, one of the surgeons over at Swedish was a very big fan of these freestyle valves, so there's a lot of them in our Pacific Northwest area. So this is a very good option, and I really commend you guys for moving this forward. Any difference that your team has seen on the bovine versus porcine valves in terms of crossing, in terms of laceration? Any tips that you would give the surgeons moving forward on this regard?
Happy?
No, it's a great question. Generally,
pull out
these
inject?
valves, the majority of the bioprosthetic valves, it really is a very easy pull.
In many aspects, they differ. Porcine leaflets they are more gentle. They tend to tear occasionally in an abnormal manner. They require less amount of energy to cross and to lacerate commonly. And it sometimes depends whether it's a stentless porcine or it's a mosaic or epic. Each valve really has its own characteristics. So we are ready to do the cut, the laceration of the right cusp. So ignore, you have 2 catheters that are related to the left cusp that will not be related to what we do now. You can hold it now. So inject.
So we're injecting the
Bovie
dextrose,
Bovie's on.
and that's the pull.
Okay.
And you can see that little bite, sort of a little extra pull that has to happen there, and beautifully traversed it. Any changes, Burkhardt, you'd like to, as they're taking the catheters out, in terms of
From here.
the way the leaflets look, or?
Yeah, there seemed to be more mobility on the right coronary cusp, and as you see it here on the
So the
left
picture is
color
going to
compare image.
Right, so the right coronary cusp being more on the bottom of the screen there. And
Right
you can see,
there.
yeah. And you see still the catheter perched on the left coronary cusp.
Yeah, over here. Actually gives me opportunity to briefly talk
Mark?
about the fact that,
Yes.
yes,
We have a question from, I think, Vasily.
Mark, can you show us the
Yeah, sure,
hemos?
Basilis.
I think that it's very interesting because a lot of time these patients, you know, we have a low diastolic, but we started with a low diastolic. And still, I think the mean
Right, so
pressure
she's,
is...
her diastolics are in the 30s and 40s. They've been that way from the beginning. I think one thing on this one, Vasilica, is that I think she'll tolerate it well because it's been very, very chronic. So we don't anticipate that much hemodynamic compromise, but obviously we're always watching carefully.
She interestingly had the really equalization of the diastolic pressures at the end of the diastole between the LV and the aorta. In about 10% of cases, maybe 15, we see true hemodynamic compromise. Sometimes we need to rush, but rarely it happens.
So two comments.
So here there's two things we're coming up.
Two comments is that you can try and pace a little faster if you're having a lot of AI. That
Absolutely
seems to
right.
work quite well. And the second comment is it may be worthwhile just to leave a pig in your ventricle rather than expose the confida. It might be, or have the confida inside the pig to keep it insulated so there's no coupling with your second burn.
Yeah, that's exactly what we're going to do. And yes, correct.
We do it in double basilica only after cutting one of the leaflets in order not to have too many sheaths. So now we cut the right cusp and we have a pictal through the big sheath, and we are able to deliver the evolute quite quickly. You can actually see the hemodynamics both in the aorta and the LV on the
Could you show the hemos? Thank you. Yeah, so you have equalization of pressures at this point.
So we don't want to interrupt you in the flow because I think it's going to be a challenging time point. So you go forward. We don't ask you questions at this time. Before you start, I want to ask you one single question about the implantation. You want to go a bit lower, I imagine, with implant.
Yes.
In this
Absolutely right. So we're
particular
going to use a
case.
core valve. Yeah, we're going to use a core valve and go a bit lower. Absolutely.
All right. So now you focus on your procedure because I think it's fundamental.
All right, thanks, Francesco. So at this point, we're about to do the laceration of the left. We're all set up.
So what we see, the pictal, I'll do cine for a second. And there is a pictal in the LV coming from the big sheath. We have 8 French AL4, and we have a multi-purpose 6 French.
And having the different sizes is helpful just to differentiate.
Yes, correct. And there is a stator wire between them, and you see a dot there. The dot is the end of the piggyback, close to the end of the piggyback micro catheter.
Okay, so just before you pull, so to Francesco's point, and we're obviously on cue for this, that once we do this laceration, we're going to try to move rapidly to get the core valve in place. And Dr. Aldea and Danny will get that position ready to go.
Yes.
So why don't we move
Absolutely,
forward?
we will need to have a pictal going through one of these sheaths in order to perform the TAVR. And this pictal will have a confida wire.
Why don't you grab the
And after that, the Evolute Pro will go over it sheathless.
Okay. So here we go with the laceration of the left.
Go a bit like that. So the pull should not be a strong pull. We do not want to have we want the tear to be a controlled tear. So inject.
So injecting dextrose.
Bovion.
Bovion. Okay. And you saw at the end the pull. And hemodynamics are still stable.
Okay.
And
So while they work, I would like to ask maybe whoever wants to answer, but maybe you, Vasilis, you think this should be always echo-guided procedure? Do you need an echo in all these patients?
You know, we've done it multiple different ways. A lot of the pre-procedural CT planning we did not see for this case, but you can figure out angles of projections for both the left and the right. I think also for those that had stented valves in place, it's much easier to see fluoroscopically and sometimes hard to see by TE. I think it's nice to confirm by TE, but sometimes you don't get as much visualization as you like. So we're using a combination, but to your question, Francisco, you could probably make a lot of this fluoroscopically driven and CT planned.
And Vasilis, what are we
stented valves
accomplishing when you're
are
injecting the
easier.
dextrose? Can you
Yeah.
speak to that?
Yeah, the dextrose. So the dextrose
Of the
displaces all salt so that you can send all the energy and not have it disperse all of it to the what we call the flying V. That's the bend that you saw Danny make, where he denudes just the inside of it. So it's actually it's a wonderful trick because you can burn indefinitely without creating char on the wire, and it's definitely part of the secret sauce of burning.
Yeah, so right now, as we're working for these cases, we obviously spend a lot on the CT. In front of us, we have written in very large, bold letters what the right front, right side view is, what the left side, left front views are. We actually have 3D models that we're doing now, sort of point of care 3D constructions. That's been somewhat helpful as well as we continue to better understand how to utilize. In terms of our imaging, we're very fortunate, obviously, to have Dr. Mackinson. The 3D images have been very informative as well. So I think putting it all together, at least this point in the evolution of the technique, it's really important to have all this synergy of information to maximize the outcomes and make the procedure as quick as possible. Okay, we're going to get a wet wipe. There you go.
So how do you decide which case to use it? Is it any arbitrary cut point of coronaries or using a simulation Phelps? When do you decide to do intend to do it all valves,
When do you decide when to
where
use
it rather than just doing valve or cracking?
When do you use the Basilica, you mean?
Cracking the annulus of surgical valve. When you go for it?
I think that Basilica should be, honestly, the treatment of choice in TAVR, in cases at risk for coronary obstruction in both native and stented and stentless surgical valves. We'll focus on the implant here, so our aim is not to be too high. It's counterintuitive for valve-in-valve cases, but this is a stentless valve-in-valve will be a bit deeper than that. Can you inject?
So we're going to try to implant this, and I think we're shooting for about 8 millimeters below, Danny.
So we don't want the skirt to also obstruct the Basilica tear, the gap. It's good. Small injection, please.
So part of the, I think in this case, I think TE is going to be very helpful with implant height. So we'll,
let's space
obviously
in
having a
120,
repositionable device is also quite important.
Pacing at 120.
You can do deeper. Gonna be deeper than that.
So one of the problems we thought we'd have with the AI as it's delivering is that we wouldn't get a picture to be stable, but at least now it's stable. We're in a little deep there. Probably just caught off the edge of the cusp.
Let's take a picture. Inject. Okay, maybe a bit higher. Yeah.
So we're a little low.
Yeah, I'll go slow. That's a good. Yeah.
Letting it flower.
Good.
So Mark, it's Anita Asgard. Just a question. For the Sentinel, since you have such extensive experience, have you noticed any increased material in the Sentinel when you do these Basilica cases, or not really?
Not for the Basilicas. We have not seen much at all. No. You know, we've done TMVRs as well, and you know, it's sort of
might be good.
unpredictable.
Pressure came back.
Not yet.
A little bit more.
No.
A little bit more. A little bit more.
I'm out.
Why don't you turn the pacing off?
Lost the pressure.
Pacing off, please.
Pacing off.
Yeah, we're just
How is the blood pressure?
The valve is not opening yet.
So at this moment there is still some obstruction in flow because I think it's a very narrow anatomy. And it's always a challenging step.
Quick return of the pressure here.
Pressure is coming back.
Yeah, we got it now.
Okay.
We're pacing at 80.
Okay. Let's keep the wire and bring a pigtail inside the
So first of all, we can already see the difference in the diastolic pressure. Very good. Very promising.
The first question that we have in these cases is whether we have coronary obstruction naturally. So maybe we'll ask Berka to see if the LV changed
16 sheet.
or
Taking
there
a
is
quick
any
look
change
now.
in the flow. We can see also the flow to the coronaries.
Yeah.
So why don't you do an injection then? First
We
of
will.
all.
We'll do it right now.
Dry session. Yeah.
We will.
we are all a bit stressed. But the heart looks very good. I mean, Maurice, what do you think?
I think it looks pretty good. There may be some regional, so we have to pay a little attention to each part of the wall, but it looks good.
Maybe
So right now it's diastolic 60, which is great, and we're still pacing, I think.
No. So diastolic pressure is excellent. You know, it's a very challenging case. I have to say, double basilica and also a stent in the coronary ostium. Really, it's Mountain Everest.
I must say that it is always our pleasure to fix issues related to cardiac surgery. It makes us very happy.
It's a pleasure to see you fixing our life. Thank you, Danny.
Danny, it's Gilbert here. How much tactile feel do you get when you pull the wire when you do the laceration?
How much dextrose?
How much tactile? I would say that it has to do with how well the electrical cutting is working. Every once in a while.
You do not want to pull too strongly. If you do the process correctly, then the pull should be gentle. It's supposed to be slightly more than creating contact. You need to enable the electricity to do the burn on the leaflet. So there are several steps that should be taught, and maybe this is an important time to say that procedure should not be attempted by people without guidance or without proctorship. Still, coronary obstruction, high-risk cases could be associated with mortality, and there are issues related to that procedure that should be taught, and it's more than just seeing our live case. And please reach out to all the team that we described that was involved and know how to do the procedure, and we can guide you through it.
There's no paravalvular leak, right?
So these are important points Danny's making. I'm sure while you guys are setting up for an angiogram, I'll make a few more comments.
One, go to hemos?
The access is very interesting. In some patients, when you have to do multiple access, you may have to go transcaval. The proctorship, I think, is important because cutting is better than a lawnmower procedure where you just pull hard on the coronary wire, because if you create that type of mechanical of the leaflet, you will have a massive hemodynamic collapse. The issues with the Sentinel are interesting. In the IDE, about half the patients got a Sentinel device and about half of them had debris in the net. It's unclear what is the increased stroke with Basilica. Certainly in the Lampoon IDE, there were no strokes, and that was, albeit native leaflet that was being cut. But I think as opposed to chimney stenting, and the funny thing about this case is that there was a right ostial stent placed for different reasons. But there's no hardware left behind typically in the old sinus, and some of these angiograms that you see afterwards in people that have chimney stented is a lot of clot, which hopefully there are other potential upsides to Basilica, which includes better watch of the neosinus, of the old sinus, maybe better coronary flow, maybe easier access to the coronaries. So to your question about who should have Basilica, still unclear. It's hard to know 100% who is going to obstruct.
Pull your
Pro back, please.
Pro back a little bit.
So what is interesting here, so echo shows very nice left main flow, but we don't see very well on angio. So it's good to have echo today.
You see the echo there?
Yeah,
echo is good. Angio, right, okay, it comes now.
Well, Francesco, if I may comment also, I think during the procedure, especially centers that adopt the technique, it's very important to have a good communication about the position of the very tip of the catheter. The attack angle can be seen on fluoro, but where you are in reference to the commissures and the coronary offtake, quite often we find that echo biplane imaging is very important to confirm the position.
So you guide Basilica by echo?
Yes, we go a lot back and forth between fluoro and echo, just to confirm.
So, right.
What's going on with the mid-distal right? You think that's spasm?
So we just opening. So since the case went so well, everybody is excited. We have a lot of comments. So John Carroll has a comment.
Yes. Beautiful demonstration. I'd like to ask you not who should have it, but who should do this type of procedure, and the type of things that come into my mind. What's the learning curve? What's the frequency of this out there in a country? And should a country like Switzerland have 3 centers doing it, and U.S. have 15? How do you see this rolling out to optimize patient care despite our hyper-competitive medical system?
Yeah, I am sure that eventually there will be a learning curve of certain operators and learning curve of the community, because we learn, we will publish, we'll present, and we will describe our mistakes. We already do it a bit differently than how we did it a year ago. But Basilica is like a hybrid between transcaval, lampoon, or wide wire techniques and PVL closure. People that are aware of these both techniques are usually people that do these procedures well. And I'm sure that with time, more and more people will be proctor and learn how to do this procedure correctly. It is growing. In the first year, the first case of Basilica was only in July 2017.
But there is some help to having cadence to it, right? We've done quite a few. The steps are repetitive. If you're not doing them every few months or whatnot, I mean, you know, it might present more of a challenge than what we currently have going on.
Right, and
I think that's
the only other,
in the
I'm sorry, go
mid-right, guys. This is Charlie.
Yeah.
Yeah, it looks like the spasm. We're going to just wait a little bit. The pressure's good. The osteum looks good. The post-procedure injection looks good.
Often, or do you
There looked like there was a little bit of spasm. I think Tamim's raising his hand of the right coronary distal. It might be worth shooting. To Danny's point.
We're just going to wait.
We're going to selective one in a second.
Yeah, we're just going to wait a little bit, and the pressure's good, diastolic's good, so the flow is good.
But we just came off pacing, so that's her regular sinus rhythm now.
To John's
EKG
point,
is normalized, but we'll do another shot for sure. Completely agree. We're just planning on waiting while we were.
Sure. So to John's point about how this should be rolled out and how it should be taught and who should be doing it, it's very important that the results are tracked. And so some of these new procedures, transcaval, lampoons, valves and MAC, basilicas, it would be great if we could get some buy-in from TVT registry and saying, okay, these are new, we don't know where they're going, but they should be tracked to understand who's doing them, what the results are like. You know, is there a box that we can add, et cetera?
Agreed. We're tracking sentinel, we're tracking valve cracking, but we are not yet tracking basilica.
Transcables and basilicas, right?
Transcable, we have alternative access, but it's hard to identify those.
Yeah.
One question that occurs to me
go ahead.
One question that occurs to me is the patient selection. You know, before Basilica, the alternative would have been to protect both coronaries, and we've done that, and then to deploy the stents if the occlusion actually occurs. Here it's a little different in that you're prophylactically performing the procedure rather than responding to an actual occlusion. And the predictors, there are cases like this where it's an almost definite occlusion, but the majority of the cases, they may meet the certain CT predictors that have been defined. Even when you meet the predictors, the majority of cases don't actually occlude, and you are able to remove rather than deploy the stents. So there is a difference between doing a prophylactic versus a responsive procedure, and you may end up doing more procedures this way. So I would sort of ask how you select, is it any patient that meets a CT criteria, you automatically do a Basilica, or are there gradations? And I think there's a lot to learn, but a beautiful procedure, guys.
A lot to know.
No, I would say a couple of things. There's still some technique issues that I think could be better understood. You know, even when we set up for this case, one of our concerns was the snaring of the wire, how long that will take, and just basically being able to manipulate the snare a little bit better in the LVOT. In terms of the guidance in the cusp, I think we've gotten quite good with the Amplatz guides and sizing them. And the piggyback and the IM, but again, there may be some more nuances to make it even a safer and quicker procedure. But in terms of actual complications from the tearing or the laceration, we really have not seen anything that at this particular juncture. So, and then that cutoff, it's usually black or white, but there is just a gray zone. I think Gabriel and I think Danny and Jamie as well have been doing TAVR for almost 10 years now, and in the last year we've done 35 basilicas now. Yeah. About 35. So it's really interesting. We hadn't done one for almost a decade, and all of a sudden we have all these cases. But it's to have it as
also
in the armamentarium.
Right. We're procedures.
So, Mark, I already start missing you because we have 5 minutes left. So it's nice to make a wrap up of this case because it was a very complex case.